Hello and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman and I'm a clinical psychologist and professor in the Department of Rehabilitation Medicine and the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. And tonight we are so pleased to welcome Dr. Claire Yang, who's a urologist with Harborview Medical Center and the VA Puget Sound Healthcare System. And she's going to be presenting tonight on the use of botulinum toxin. Often we hear about Botox to treat bladder spasticity. And so I'll turn it over to Dr. Yang.
Hi, good evening. As Dr. Hoffman said, I'm a urologist here in the Seattle area associated with the University of Washington hospitals, including Harborview, and I've been the staff urologist for the VA Puget Sound Healthcare System's Spinal Cord Injury and Disease Unit since 1993. So I've had a bunch of experience with spinal cord injured patients, probably taken care of many hundreds of them, and we're going to be talking about what botulinum toxin can do to help with neurogenic bladder symptoms. So many people have heard about Botox, which is one of the brand name forms of botulinum toxin, but we typically hear about it in the context of people using it to get wrinkles out of their face for cosmetic purposes. But there are actually a number of medical uses for botulinum toxin, and we'll go into that later on in the talk. What we're going to cover tonight is what is botulinum toxin, and in order to describe what it can do for the bladder in the spinal cord injured patient, we're going to talk about what bladder function is supposed to be doing, and then what changes occur after spinal cord injury. We'll talk about how botulinum toxin injections treat neurogenic bladder symptoms, how it works, how it's done, who can benefit from the treatment, the effects, how long it lasts, and we'll talk about what botulinum toxin does not do, and some research on bladder chemodenervation, which is the formal name for toxin injection to paralyze the bladder. So to start off with, botulinum toxin has a long history. The first description of food-based botulism was in 1817, and that was a description of how people got sick and had trouble breathing, had trouble swallowing, and died from eating affected food. It wasn't till almost 80 years later that the toxin which caused these problems in the affected food was found to be produced by a particular bacterium called Clostridium botulinum. Fast forward another 50 years, 1950, the mechanism of botulism and toxin was discovered, and that's when scientists got the idea that the effects of botulinum toxin were by blocking nerve signals to muscles in the body. In the 1970s, the toxin was first studied for human use in a medicinal purpose. 1988, the first report of urologic use of this botulinum toxin. And in the 2000s, a number of studies, starting in Europe and extending to other parts of the world, studies of toxin use in the bladder and the urethra. So medical uses of botulinum toxin, we talked about wrinkles. You know, you might not think that's exactly a medical use, and it perhaps isn't really, but there are true medical uses for botulinum toxin. Many spinal cord patients get botulinum toxin injected into muscles of their arms and legs and hands for muscle spasms. People with eye twitches that are bothersome and impede vision, get their eye muscles injected, eyelid muscles. That's called blepharospasm, I'm sorry. Hyperhidrosis is a condition where people have excess sweating, and botulinum toxin injections can help with that. Migraine headaches, some forms of migraine headaches are due to scalp muscle tension, and that injections of the toxin into the scalp muscles can be very helpful for these people. Achalasia is a problem with swallowing, and one of the ways to treat it is to paralyze some of the swallowing muscles that are overacting, and then that helps with the swallowing difficulty. And then in anal fissures, so where the anal sphincter muscles are paralyzed, to help the fissures and the infected areas heal. So how does this toxin work? Well, muscles in the body contract or spasm in response to signals from nerves. And what botulinum toxin does, that molecule blocks the nerve signals from getting to the muscle, and that then paralyzes the muscle. So at the cartoon on the bottom of the screen, if you were to imagine a very, very powerful microscope looking at the tip of a nerve, that's the yellow part, and the pink part is the muscle cell. The way that a nerve signal sends a signal to a muscle is by releasing little chemicals onto the muscle. But on the right picture, you see a red line at the bottom of this nerve, and that's what the botulinum toxin does. It prevents the signal from spreading across to the muscle cell, and so if the muscle doesn't get the signal, it doesn't contract or spasm, and it's paralyzed. Some of the forms of botulinum toxin available for medical use in this country and in Europe are listed here. There are 7 forms, I believe, of botulinum toxin, and 2 of them are in use, especially in this country. The A form, Botox, made by Allergan, Dysport, made by Galderma, and Xeomin, made by Merz, and the B form of the botulinum toxin, Myobloc, by Supernus. You may hear about these different forms of botulinum toxin in advertisements or from your providers. Now, in order to understand how botulinum toxin works for symptoms of the neurogenic bladder due to spinal cord injury, it's helpful to know what the bladder is supposed to be doing in the healthy state. And so we'll describe a little bit of that, and then talk about the changes that occur with spinal cord injury. So in this picture are the organs that are part of the urinary tract, and at the top of the picture are 2 kidneys. The kidneys filter the liquid poisons out of the blood and puts it into the urine. The urine then drains down from the kidney down the 2 ureters from the right and the left kidney, and then the ureters plug into the bladder where the urine collects in the bladder. The bladder holds the urine until it is full and until it's socially appropriate to evacuate, and it holds on to the urine with the sphincter muscles, which are located at the opening of the bladder. And when it's time to empty, the bladder empties the urine through the urethra. Now, if we were to drill down onto the bladder part of things, you'll see a picture here. The ureters are coming into the bladder here and here, and then they plug into the bladder. If we were looking on the inside of the bladder, you'd see 2 little holes. Then there are two sphincter muscles, the internal sphincter and the external sphincter. And those are the muscles that hold the bladder closed so that the urine doesn't leak out. And the urethral orifice, this is a picture of a woman's bladder. In a man, the urethra would be a bit longer. And the sphincter muscles close and keep the urethra shut so that the urine doesn't leak out. But there's even more to the urinary tract than what I showed on those two. And this is a cartoon showing all the connections of the bladder and the sphincter to nerves that then connect to different parts of the spinal cord. So in order for the bladder to work as it should, all these connections need to be healthy and intact. And you don't need to know the different connections here, but you can see that the bladder is connected to the spinal cord at different levels, and the sphincters are connected to the spinal cord at different levels. And then the spinal cord sends signals to and from the brain to the bladder and the sphincter. So there is a lot of coordination that has to happen between the brain and the bladder, and a lot of signals that are being sent back and forth constantly. And in order for healthy, normal function to occur, all these signals have to be going back and forth in a very, very efficient fashion. So what is the bladder supposed to do? The bladder has basically two functions. It needs to store urine, and it needs to store it at low pressure so that the container of the bladder's reservoir function or container function is to hold urine in it, but not just hold it, but hold it at low pressure until it's socially acceptable to empty. And we as humans, after we're toilet trained, have deep-seated ideas about when we should and shouldn't empty our urine. And then when it is time to empty, the urine empties by the bladder squeezing. And before the bladder squeezes, those sphincter muscles have to open up, so those things have to be coordinated. And the bladder has to squeeze efficiently and completely so that the bladder empties in one fell swoop, one fell contraction. That's basically healthy bladder function. This is a cartoon showing what's going on. So at the top is the bladder with the sphincters closed, and this is during the filling. And then this is detrusor pressure. Detrusor is another word for bladder muscle. So the pressure is low. This is, on the y-axis is pressure. And on this bottom graph is urine flow, and so there's no flow going on. But as the bladder fills, and when it does get filled, then the sphincters open. And then once the sphincters are open, the bladder squeezes or contracts. And that's when the pressure in the bladder goes up, demonstrating that the muscle of the bladder is squeezing the urine out. And you can see that by the flow rate of urine that comes out. And then when the bladder is empty, the sphincter muscles close again, the pressures fall, and there's no urine flow. So what happens with spinal cord injury? Many people call the changes neurogenic bladder, and neurogenic just means based in nerves. And we use that term neurogenic bladder, meaning to talk about, to describe bladder problems as a result of nerve disease or nerve injury. So as I mentioned earlier, healthy, intact nerves, spinal cord, brain are needed for healthy bladder function. And so when some of those or all three of those components are injured or damaged, you get neurogenic bladder, and that's bladder dysfunction because of neurologic injury or disease. So back to this cartoon, the blue bar across the spinal cord, if there is this disruption in the spinal cord, all the signals from the bladder and the sphincters can't travel up to the brain to be coordinated and organized so that the bladder squeezing and holding on to urine, those functions are disrupted. What are those changes that occur after the spinal cord injury? So on the left hand of the slide, I describe the healthy bladder functions, storing urine at low pressure until socially acceptable to empty, evacuate urine efficiently and completely, and then following SCI, we have loss of the ability to store urine. And part of that is because the low pressure storage function gets lost. And so the pressure in the bladder as it's filling up isn't low, the bladder isn't stretchy and elastic, and the bladder wall gets thick, and so that the pressures build up with just a little bit of urine, and when the pressure builds up, it's not very healthy. Sometimes there's loss of urine leaking out of the bladder as a result of those high pressures. The other thing that occurs that prevents urine from being stored is the bladder becomes like a baby's bladder. Before babies are toilet trained, their bladder fills up a little and squeezes, fills up a little bit and squeezes. There's no brain control over the bladder. That's because their nerves and spine and brain aren't mature enough to exert that control over the bladder. But when they reach an age old enough to have those nerves send those kinds of signals to control the bladder, at about age 3 or so, then the bladder can come under control and we can hold on to our urine until it's socially acceptable. But with spinal cord injury, that control from the brain gets lost, and so the bladder fills a little and squeezes, fills a little and squeezes, and that's sort of the overactive bladder that people have with spinal cord injury and other nerve diseases. The bladder also loses its ability to empty completely. So even though it might be squeezing when it's not supposed to, it doesn't squeeze efficiently, and so the bladder doesn't empty effectively or efficiently, and many people can't empty their bladders at all, and that's called urinary retention. Another thing that changes is that the sensation of bladder filling is partially or completely lost. And without that sensation of filling, without that sensation of knowing when you're full, there's no way to control the bladder's evacuation or emptying. So loss of bladder sensation is a big part of all the dysfunction that occurs. I will say, though, that these changes don't occur in all spinal cord injured patients. It depends on the severity of the spinal cord injury, the completeness, if you will, and at what level. People with very low spinal cord injuries, lumbosacral spinal cord injuries, don't have that bladder overactivity. They only have the inability to empty their bladders. So how do these changes show up in a person in everyday life? The loss of ability to store urine results in urine leak or incontinence. And the high pressures that are generated in the bladder can be perceived as bladder spasms. They can cause autonomic dysreflexia, infections, and kidney damage. The loss of urine control, the incontinence, is unhygienic. Nobody likes it. It's inconvenient. It can cause skin breakdown and rash. And the inability to empty the bladder is called urinary retention. And if the urine can't get out of the body, we need to use catheters to help drain the urine. And with catheters comes an increased risk of infection and then the inconvenience of using the catheters. So that was a lot right there, and I can pause right now, and if people have questions about healthy or neurogenic bladder function, changes to the bladder as a result of spinal cord injury, I'm happy to answer those questions at this time.
So a couple questions that have come up. One is, are there the different forms of botulinum toxin? You mentioned that there's 7, but kind of talked about A and B. Do they do different things, or do they all generally do the same thing, but they're just how they're created?
They generally do the same things. Only certain types are available for bladder use at this time because only a couple forms have been selected to be studied. And so the forms we use are the ones that have been studied.
So another question is, do people with spinal cord injury tend to recover bladder function, or does it stay the same? Like once you have an injury, it's going to be the same over time?
Well, with all spinal injury, there is a period of recovery. And generally speaking, if what you have after about a year is what function you're going to be having going forward. Most recovery will occur within the first 12 months, and that goes for bladder function as well. I will say that the nerves to the bladder are different from the nerves to the legs and arms. So even if leg function recovers significantly, it may not follow, it could, but it may not follow that internal organ function like bladder function will recover to the same degree.
Okay.
All right, well then we'll move on to the next section of the presentation. Bladder chemodenervation. And chemodenervation, denervation means taking away the effects of the nerves. And chemo means doing that, taking away the effects of the nerves using chemicals. And so that's what botulinum toxin does. It's a chemodenervation agent. It takes away the effects of the nerves. And we do that in the bladder by injecting the botulinum toxin solution. So what can chemodenervation help with? Number one, bladder spasms. And as we mentioned earlier, bladder spasms are a result of the high pressures generated in the bladder because of spinal cord injury. This can lead to autonomic dysreflexia. A lot of people feel that their AD symptoms are rooted in bladder irritation or bladder spasms. Bladder spasms can also occur provoked. The bladder spasms can be provoked, and the most common time is with catheter changes. People will get severe bladder spasms with catheter changes, setting off AD or a lot of discomfort. In spinal injury patients who perform intermittent catheterization, leakage of urine occurs due to the high pressures in the bladder or due to bladder spasms, and bladder chemodenervation, botulinum toxin injections can help with that. Some people experience difficulty with catheter passage with intermittent catheterization, if that's due to spasm of their external sphincter. The external sphincter is a muscle, just like the leg muscle, or in spinal cord injury, those muscles can spasm, and if that's what's keeping the catheter from going in, there are other reasons a catheter might go in, and botulinum toxin won't address it, but if it's due to muscle spasm, that's what can help. And if people are taking medications, oral medications for bladder spasms, but the medications cause severe side effects, or if they don't work, then we progress on to bladder injections. But usually, and in many cases, insurance companies ask that people try the oral medications first before going to bladder injections. You know, it's necessary to try these medications first. But if they don't work, or if they're causing bad side effects, then we move on to the injections. How it's done is typically by a urologist. This is not a difficult procedure. Most urologists are able to perform this procedure. Now, many urologists also have specialized practices, and so, say, a kidney stone expert or a cancer expert wouldn't be doing this kind of thing, but most urology residents are trained in their training program to do this. It's because it's not very difficult. There are urogynecologists, so gynecologists who specialize in urinary problems who do this, but they don't typically see male patients. Occasionally they will for something like Botox injections, but typically they don't. And many urogynecologists don't see or don't feel comfortable with taking care of people with spinal cord injury. Not all, but some don't. So typically it's a urologist who will be doing this procedure. It can be done in the office or as outpatient surgery. In the office, that's typically for people who don't have a lot of difficulty with autonomic dysreflexia, or who aren't too difficult to transfer onto a procedure table. So if, for whatever reason, you have a lot of autonomic dysreflexia associated with your bladder, that might move your procedure to the operating room with anesthesia so that the AD or the dysreflexia can be treated easily. Otherwise, it can be done in the clinic under local anesthesia. The provider might ask persons prior to the treatment to be pre-treated with antibiotics, may or may not, depending on their preference, to minimize the risk of infection. Injections are done with a tiny needle through a cystoscope, which is a telescope that the urologist places into the bladder, and I'll show you a picture of that, and then the solution of botulinum toxin is injected through the tiny needle, and it takes about 10 or 15 minutes. Quick, easy procedure. So the picture here shows a urologist who's standing up and the patient who's lying down, and there's a little drawing of the internal organs showing that the cystoscope is going into the bladder, and the screen at the top of the picture is that of a bladder tumor. So this is from another picture, just showing the procedure, not what we're talking about. Enlarged, so here is the cystoscope entering the urinary tract, and what we're looking at are the internal organs looking into the bladder from a side view. So the bladder is shown here, and the cystoscope is the telescope with a light on the end of it that allows us to look inside the bladder, and the cystoscope is going through the urethra and into the bladder. Now, if you were to change from the sideways view to the front view, so the cystoscope is shown here going into the bladder, and then you can see a little needle, a silver needle extending from the tip of the cystoscope. The white circles throughout the inside of the bladder are the points in a grid-like fashion that the botulinum toxin is injected so that it's spread throughout the bladder. So it's not a solution that's just sloshed around the inside of the bladder. It's injected into the wall of the bladder so that the nerve muscle connections can be soaked with this solution, and then the nerve signals can be blocked. And so these tiny little needles, we make about 20 injections throughout the inside of the bladder. The effectiveness of botulinum toxin injections can be seen within a week. I tell people that their bladders might be more irritable or more irritated for the first few days after the injection, but then it'll calm down, and within a week, people will notice a difference in their symptoms. Overall, it's very effective. Many studies have looked at the effectiveness of these injections to calm down or eliminate bladder spasms. It can increase the stretchability of the bladder so that it can store more at more volumes or higher volumes of urine at lower pressures. And as a result, the quality of life of people who have these symptoms is improved significantly. There's a lot more comfort, there's a lot less incontinence. These effects can last anywhere from 3 to 12 months. And that duration of efficacy is based on the level of injury, the completeness of the injury, and how long the patient has had the spinal cord injury. Typically, with a high injury for a long time, the efficacy is on the lower end, on the 3 to 4 month end. But an incomplete injury at a lower level, the efficacy can last for many, many months. You can get repeat injections, and in fact, most of my patients are really quick to call my office as soon as they think that they are losing efficacy, because the symptom improvement is so profound. However, for people who are getting injections of botulinum toxin in other parts of their bodies for spasticity in their legs or arms, you are not supposed to get more than 400 units of botulinum toxin every 3 months. That's for Botox, that formulation. It's a slightly different number for other formulations, but approximately 400 units for Botox. We typically inject 200 units for a bladder injection. So you and your urologist can keep track of how much you're getting if you're getting it in other parts of your body. You can lose, the Botox, botulinum toxin can lose its efficacy. In spinal cord injury, bladders can get scarred. They can get thickened because of the changes that occur as a result of spinal cord injury. And scar tissue doesn't respond to botulinum toxin, only muscle tissue does. And then on rare occasions, people build an immunity, develop antibodies to this toxin. This toxin is a foreign material in your body, and your body generates a reaction to it. In some people, that reaction is strong enough so that the toxin is attacked by your immune system and neutralized before it can have its effect. And in those situations, we typically switch a formulation of botulinum toxin so that you can get efficacy. And then one question that a lot of people ask is one brand better than the others? There are only a couple available in the United States for bladder use. One, Botox, that formulation has been studied more in this country, and it's just more widely used. And Dysport is the other one that's used for bladders in this country. The side effects are actually very few. There are no severe effects reported with bladder use. For example, death or paralysis due to the toxin. The local side effects are typically related to infection, UTI, or blood in the urine for a few days. In some people, their bladders are very scarred up, and so there's quite a bit of bleeding that can happen after the procedure. There are rare reports of muscle weakness and difficulty swallowing in using botulinum toxin injections, not in the bladder, but in other muscles like of the neck and things. And so I just bring this up because in theory it is possible, but it's extremely rare. And then what botulinum toxin injections do not do, it does not make the bladder squeeze. It does not allow it to empty. It paralyzes the bladder, and so there is no squeeze, or there's very little squeeze left. So if you're thinking that it can help you with voiding on your own without a catheter, it will not do this. And it certainly does not allow the patient to void as he or she did prior to spinal cord injury. Insurance does cover this. The government insurances definitely do, Medicare and Medicaid. And private insurances do. In many instances, they require that you have tried oral medications to manage bladder symptoms, and you have to be able to document that, or have side effects from oral medications. Now, just a little bit here at the end, research on bladder, chemodenervation, and SCI. I've been, as part of my patient care responsibilities over the years, I've noticed a lot of things that have affected people as a result of the botulinum toxin injections in their bladder. And in 2018, we wrote up a paper that people not only got benefits from their bladder, but they also noticed improved abdominal and leg spasticity. It turns out that decreasing bladder spasms results in less belly and leg muscle spasms. It doesn't eliminate it, but it does decrease it, showing, and that can be explained because the spinal cord is supposed to help regulate muscle activity, and sometimes in spinal cord injury, when the spinal cord can't help to regulate it, and so things like bladder spasms can set off other abdominal or leg spasms too. So when the bladder is calmed down, the other muscles are calmed down too. People have reported less autonomic dysreflexia. And finally, people report the perception of less frequent urinary tract infections. And the reason for that is not because botulinum toxin kills bacteria. There's still the same amount of bacteria in the bladder. It's just that the bacteria can cause bladder irritation, and then people think they have a UTI because they've been told by their providers, oh, you must have a UTI, you must have a UTI. And once the bladder is paralyzed and no longer spasming and irritated, that sensation of having a UTI, or what's attributed to a UTI, is gone. So people feel like they have less UTIs. Now, I will say that none of this is sort of on a formal indication for autonomic dysreflexia. It's just our report, or botulinum toxin injections. It's just our findings in querying patients who've had bladder. And these are not FDA-approved indications. Another research project that I'm trying to get off the ground is early chemodenervation. So we have noticed, other people have noticed that changes to the bladder, that thickening, that scarring can happen very soon after spinal cord injury in humans, and we have a rat model that demonstrates it. And so the bladder loses its ability to store, it's less elastic, and the bladder doesn't respond as well to the botulinum toxin injections when it gets thickened and scarred. So I'm trying to get a study going where we do bladder injections of botulinum toxin immediately or very soon after spinal cord injury to preserve the bladder tissue stretchability so that it can hold urine better, so it's not as irritable from the get-go, and maybe preserve it for the long term. All righty, time for more questions.
We have a bunch of different questions here, so I'm just going to kind of jump in, and hopefully I'll get to everything. I might go back and forth just for people watching. Is there a limit to how many times a person can have a Botox injection or botulinum toxin injection in their bladder?
Not that I know of. I have patients I've been doing injections on for over 10 years. So these are the people whose bladders haven't scarred down, and so there's no limit, but there is a point in many people's course where it's no longer going to be effective.
Right. Is there any, just my own follow-up, is there any prediction about, other than scarring, is there any sense of kind of who will have it last longer or who won't? Can you tell ahead of time?
I have a sense of that. I can't predict anybody's particular pattern, but typically, so here's a comparison. I have several hundred multiple sclerosis patients as well, and they have spine lesions, but they don't have as severe a spine damage as in spinal cord injury. And for those people, many of them are getting their injections once a year, and they get it, and they get good efficacy for a long time. Now, for those MS patients who have progressive MS and have a lot of spinal lesions, I notice that their bladders get scarred down and thickened just like in the spinal cord injured patients, and so then their efficacy starts to shrink down and the interval of efficacy is shorter. So in the spinal cord patients, those people who have high complete injuries typically have shorter efficacy intervals. The people with lower thoracic injuries, if they're not complete, they can have long periods of efficacy.
Great. If somebody has a suprapubic catheter, can you go through the stoma of the suprapubic rather than the urethra to do the injections?
Yep.
Is that pretty common?
Yep. And so it's just any way to get into the bladder is fair game, and it doesn't make it better or worse. It's just a way. Some people who have suprapubic tubes have scar tissue in their urethra, which makes it difficult, if not impossible, to get the telescope in through the urethra, so we have to go through the stoma. And we'll change out the tube at the same time. So.
There's a question about the use of oxybutynin, I think is how you pronounce that. And is that something that can be used with Botox, or is there kind of any reason why you couldn't be using like both at the same time?
Well, oxybutynin is very effective at preventing bladder spasms, but for many people it causes side effects. And so when the oxybutynin can't be tolerated or is no longer effective, that's when we go to the botulinum toxin injections. Now, there are people who use the oxybutynin to extend the efficacy of comfort, if you will, from the botulinum toxin injection. And so they may have an injection, and then when their symptoms start up, take the oxybutynin for a month or two until it's just not very tolerable, and then come back in. Some people get the injection and then top it off with a little bit of oxybutynin to get them to the level of bladder calmness, if you will, that they want to be at. So there's nothing that prevents you from doing both at the same time, but typically we do the injection to get people off the medication because it's causing side effects.
Is there any risk of the needle penetrating through the bladder wall?
There is a risk, but there's no complication of that. So, you know, if you have 1 or 2 squirts of botulinum toxin that is outside of the bladder, it's not going to cause any side effects.
Okay. So nothing to be super concerned about. It can happen, but it's not that.
No.
Are there any studies on timing of scarring? So if you were to get Botox injections as a child, would you expect scarring to happen from the injections, or would it limit how you might be able to control your bladder over time if the Botox isn't working any longer?
So I don't think we know the answer to that question. Pediatric urologists were not quick to do these injections in children, and typically these are children with spina bifida who would have a same pattern of bladder problems as spinal cord injured patients would have. So we don't know, we don't have a lot of long-term data in children, but it looks like it's very effective, and there are no complications of continued use. So I don't know the actual answer to the question, but I don't think that there is any problem with carrying through to adulthood, and if the bladder doesn't scar up from the spina bifida or the spinal cord injury in the child, then it should continue its efficacy.
So just to follow up on that, is there, I mean, it's the injury itself can lead to scarring of the bladder because of all the different things going on with it.
Right.
Does the Botox injection also potentially cause scarring, or is it, you know, you're talking about preserving.
Right.
Actually, so
I
just want to clarify that.
Yeah, I don't think we have any evidence that it does. Okay. We have a lot of women and men who don't have nerve damage or diseases that get botulinum toxin injections, and they don't seem to develop scarring, and they'll have years and years of that.
So potentially, as you said, it's a great study to look early and see if you can actually protect bladders, and then potentially have it be a longer, even longer lasting treatment for bladder spasms.
Exactly.
Okay. Just to, I think you've covered this, but just to make sure, will early chemodenervation be a one-time treatment? So if you did try it earlier, would it be a one-time, or if it isn't, would you tend to build up, do you think people build up a tolerance quicker?
No, it's not going to be a one-time thing. Nobody has their bladders permanently paralyzed by these injections, so it always has to be redone. We are thinking that if we can get these injections started before the scarring and thickening happens, maybe we can slow it down, so over the course of many years buy more bladder health, gain more bladder health for the spinal cord injured patient. And the second part of that question?
Will it lead to building any more tolerance, like going early?
I don't believe so, because I think that tolerance phenomenon is uncommon, and it doesn't seem to be related to the length of time that you've had it.
There was a question from somebody about once you're doing Botox, once you stop those, does it matter? Do you have to change how you empty your bladder? Would it require you to change, like if you're using a suprapubic catheter, would that still be your use, or still if you're doing intermittent? Does that change your bladder management, I guess?
It does not change your bladder management. It hopefully will make it better.
And then once, if Botox does stop working for folks, what can someone do to bypass or help or stop those bladder spasms once Botox isn't an option?
Yeah, at that point, if medications, oral medications and the injections, bladder injections don't work, and there are bladder spasms, high pressures, that's when we start talking about surgery to increase the bladder capacity, and or doing an operation that we call an ileal conduit, where the kidneys are disconnected from the bladder and plugged into a piece of bowel, and that piece of bowel then drains the urine from the body into a bag. Many people call that a urostomy, but urologists call it an ileal conduit. So the treatments involve major surgery after that
so
point.
we kind of try everything beforehand.
Yes.
Yeah. If the perception of a UTI isn't actually a UTI, what is it, and what do you do about it?
Well, so many people with spinal cord injury have chronic catheters, and with the presence of a chronic catheter is the presence of a lot of bacteria in the bladder. And the point at which something is an infection or just an irritation, there's no test to distinguish that. What I have told my patients is that I don't want to call all bladder irritation a UTI, because if we're going to do that, then the expectation is that we're going to give people antibiotics. And because there have been no new antibiotics developed, no new classes of antibiotics that have been developed in the world in the last 15 years or so, and we're developing superbugs, using antibiotics frequently is a bad thing, and not in anybody's best interest. So what I try to do is help people wrap their brain around the idea that just because your bladder's irritated doesn't mean that we have to treat it with antibiotics. And one way is to increase your urine output to wash things through. Another way is to consider it to be bladder spasms, and we would treat those periods of irritability as bladder spasms with oral medications, or we could paralyze the bladder and decrease the irritation that way. So,
so not always an infection.
Right.
Key piece. We've talked a lot about bladder scarring. What causes bladder scarring? What are the reasons why people are having bladder scarring from their injuries?
Well, one of the reasons is that there are signals from the spinal cord to the bladder that tell the bladder to stay relaxed, to be stretchy, so it can hold urine as the urine comes in. The typical adult can hold maybe 20 ounces. You know, as we get older, that volume gets lower. And if those signals to the bladder from the spinal cord don't get to the bladder, those signals to stay stretchy, then the bladder loses its stretchiness and gets scarred down. Another thing that is can cause bladder thickening and scarring is chronic irritation. You know, people get bladder stones, people have catheters, that's, I think, a smaller part, because I have many patients who are not spinal cord injured, who have catheters for many, many years, and their bladder still maintains stretchability. They just can't squeeze the urine out, and that's why they use catheters. So they have the irritation of the catheter present, they have the bacteria present, but the bladder still maintains its stretchability. So I think it's something about the spinal signals that causes that scarring.
Yeah, and you mentioned that's still under
Yes.
research, still
Yeah.
trying to figure that out.
Uh-huh.
Is Botox equally beneficial for men and women?
Yes. Mm-hmm.
So no difference there.
Mm-hmm.
And then if the bladder does not empty and retains urine, do Botox injections help with that specifically?
No, because the bladder is paralyzed, the bladder muscle is paralyzed, so any squeeze that was present could be ablated, could be taken away by those bladder injections.
Okay. And the scarring that we were talking about, is that something that can be monitored by the cystoscope or an injection, or is there some other way that urologists monitor scarring and try and keep track of that?
Well, typically the people who develop the scarring are the people who have chronic indwelling catheters. And as long as the urine is draining and the bladder doesn't really need to have that much storage capacity. And so functionally keeping track of that is not, and it happens so slowly, you know. Yes, it starts happening early, but it does happen slowly. There's plateau phases, so keeping track of that isn't clinically necessary.
It doesn't really change your
Right.
Treatment approach,
Yeah.
potentially.
Mm-hmm.
So someone's mentioning that they've had to take antibiotics every time before they do their bladder Botox, about twice a year, because of reoccurring colonization. And in order to try and reduce the amounts of antibiotics, are there any best practices or ways to take care of their bladder in order to not have to take these antibiotics ahead of time?
Well, it depends if somebody. So twice a year, antibiotics prior to the procedure, that's not a lot of antibiotic use. And so in the grand scheme of things, I wouldn't worry about that. The urologist probably doesn't want to give somebody a UTI by injecting something into a bladder with a lot of bacteria, and that's the thinking there. So I would not worry about twice a year use. But generally, if people have an indwelling catheter, you're not going to be able to avoid bacteria in the bladder. And so there will be some pre-treatment that is necessary or desired by that particular provider. If somebody's on intermittent catheterization, you are also prone to bacteriuria, bacteria in the urine. But typically the levels of bacteria aren't that high, and you can minimize that by just regular catheterization. Some people like to take cranberry tablets to minimize the risk of UTI, and that's possible with intermittent catheterization and cranberry tablets. But I think anybody who's using a catheter is probably not going to be getting away with completely clean urine. And in reality, people without catheters who don't have a spinal cord injury don't have sterile bladders either, okay? It doesn't grow out anything. Bacteria doesn't grow out on the culture, but the urinary tract is by no stretch of the imagination sterile. So it's just the amount of bacteria that we see when we get those cultures.
So a little pivot to not necessarily a Botox question, but there's somebody that has had a suprapubic catheter and recently started having urine go through their urethra. And so there's still a lot going through the suprapubic catheter, but also going through the urethra. And is that a common thing to happen over time?
It can happen, and it might be due to bladder spasms. So, and this is especially true in women who don't have a prostate blocking their bladder outlet. And so in many of my women spinal cord injured patients who need a chronic catheter, I try to get their urethral catheter out as soon as I can to avoid erosion of the urethra. So I put suprapubic tubes in them, and I typically will give them bladder injections of botulinum toxin on a regular basis to prevent them from leaking out their urethra. So it's a very common occurrence in women who have suprapubic tubes to leak, and a lot of my patients come for Botox injections for that.
So it helps in that way as
Yeah.
well. Because even if it's not irritating, it might still be causing something, some other problem.
Yeah.
All right. Thoughts on bladder augmentation, pros and cons of bladder augmentation?
So bladder augmentation is one of those operations that I mentioned earlier that we consider when the oral medications or the botulinum toxin injections don't provide enough storage function for the patient, for the person. A bladder augmentation is only going to work well for certain people. You have to have regular catheterization. You have to be able to catheterize regularly. You cannot forget to catheterize an augmented bladder because it can expand and burst and become a surgical emergency. You have to be healthy enough to undergo a big operation. You have to be willing to, tolerate several-day hospitalization. And so if you have a lot of other medical problems, or if your injury is so high that you can't do intermittent catheterization, or your injury is so high that you have difficulty breathing on a regular basis because you will have to be on a ventilator for a long operation. All these things sort of play into that, and so it's a good operation for the right patient, but you need to discuss this in depth with your surgeon, all the pros and cons.
Perfect. One last question is, how much leaking is too much leakage?
So I tell people that leaking is a quality of life issue primarily. It doesn't bother me if my patient leaks, okay? Now, can that make decubitus wounds worse? Yes. So if you have decubitus wounds, that wouldn't be a good idea. But leaking in and of itself isn't a sign of a problem that things are getting, it's not something that you have to treat necessarily. So I leave it up to the patient to decide how much is too much, and what's bothersome to them, what's bothersome for their caregivers, and how are other things. But leakage in and of itself doesn't cause urinary tract infections. It's primarily, not everything is related to quality of life, but primarily a quality of life issue.
Great. And then a ton of thank yous. So, Dr. Yang,
Okay.
thank you so much. This is fantastic information and very informative. So thank you so much for joining us today.
Yeah, my pleasure. I tell people that every patient with a spinal cord injury has some changes in their bladder function because the nerves to the bladder come out of the spinal cord at the very end of the spinal cord, and so every injury above that level, which is every injury, is going to impact the bladder function.
Yeah.
So.
Your profession is highly needed in this population. So thank you so much.
All righty, you're welcome.